individuals' brains do not observe the world in a way that they can learn the unspoken social rules that are out there. So what does this look like? In a young child, this can look like a difficulty in back and forth. You may be calling out your child's name and they don't respond by turning their head. They may seem disinterested. They may have poor eye contact. They don't know the unspoken rules, like I said. They may appear introverted or often seek to be alone. They might have difficulty developing spoken language and most certainly will have difficulty expressing their thoughts in spoken language. And we know that they will make social blunder after social blunder. And it's not that a person with autism is unaware that they're making the blunder. They just don't necessarily know how to correct it unless someone explicitly teaches them. People with autism seem awkward and odd, and it's this social communication deficit that causes that. Restricted and repetitive behaviors, the second part of the diagnosis. If you look at those words, they seem kind of difficult to understand, but restricted meaning limited. A brain with autism is interested in or can only manage a limited amount of topics or stimulation. Repetitive means that the brain wants to stay with what's familiar and repeats those familiar things over and over and over again. What can this look like? It can look like body movements, flapping hands, pacing, but in individuals who have learned how to modulate that behavior, it might look more like an insistence on sameness, difficulty with transitions, obsessive compulsive behavior. They may have an intense reaction to sensory input, sensory things that you or I may not even notice. They may be very black and white thinkers because their brain can only recognize one truth. And so this can cause perfectionism. It can cause an insistence on rightness. So we've talked a little bit about what autism is. I want to talk about autism, the diagnosis, as it affects people who are touched by autism, parents, children, adults. I wanted to put this up there because in 2015, there was a reclassification of the diagnosis of autism. And I do think that that's something that is misunderstood by some individuals. In 2015, they took diagnoses like PDD, pervasive developmental disorder, Asperger's, and they have taken all of that and said this is all autism spectrum disorder, but they put it on a level based on the amount of support the individual needs. So level 1 requires support, level 2 substantial support, and level 3 very substantial support. Note that at every level on the autism spectrum, the individual does require support. I got to be friends with Barbara Doyle this week. It's really been a pleasure. She was going to be on our panel and was not able to. And so we've had some email exchanges. And I think something she's very passionate about, and I know speaking to the other professionals who are on the panel, I think we all agree, there is a fear around telling your child that they have autism. There's a fear about telling the world that your child has autism or telling the world that you yourself has autism. I'm just going to read this quote to you because I think it's so nice. Why would we want the person with autism to be the one who doesn't know they have it? Why would we want them to be unprepared for life and not have the skills that were targeted and to support them? You know you've arrived, so to speak, when the child or adult recognizes how autism is affecting them but not defining who they are or what their choices are. I have a personal experience with the diagnosis of autism at the age of at the age of third grade. I started noticing some real challenges in my son. And in fourth grade, he was given the diagnosis of PDD-NOS. We were involved with several different professionals at that point because he was having a lot of difficulty. And some of the professionals were telling me he was on the spectrum and some were telling me he wasn't. Guess who I believed? I believed the people who were telling me he was not on the spectrum. Due to continued difficulties, we had him reassessed right before his freshman year of high school. And at that point, the diagnostic criteria had changed and he was diagnosed with autism level 1. We told him, Dr. Leskis and I were in the office and told him that he was on the autism spectrum, and he had no reaction while we were in the office. But as we got into the car, into the parking lot near the car, he looked at me and he said, "Wait, I have autism?" And I said, "Yes." And he started to cry. And at that moment, I wished so badly that doctors walked their patients to the car. I didn't know what to do. We got in the car. He cried it out. I think the first thing he did when he got home was look up famous people who are on the autism spectrum. And from then on, we started to develop a language around what was happening in his life. We were able to seek out supports that were appropriate for him. And that was really the turning point in his success to date. So right now, I'm happy to say that his biggest difficulty or challenge he's facing is trying to decide where he's going to go to college next year. So we're very thankful for that. I wanted to bring up the fact that because I've been in communication with my university students, there is a movement out there among adults with autism that is autistic pride. This student told me that these adults prefer to be called an autistic person rather than a person with autism because it's part of their identity. I'm not going to go too much more deeply into that. I think that one statement I'd like to make about that is we want to get to a place with people who have autism where they can show their autism, where they can be the autistic person that they are in a world that understands differences, but that doesn't take away the challenges that occur when a person is before they're diagnosed and when they're first diagnosed. Autism spectrum disorder is a difficult and challenging way of life. And so just wanted to kind of go over that. I took some quotes from some of my university students. This quote, I'll just summarize. He's talking about a stigma. The question I asked was, if there's one myth that you could be dispelled, what would it be? And he said, I would like to kind of disassociate the word autism from the word disability. That if people could just see people for their differences, the things that are needed to support a person with autism very well may support many other people in the same environment. This is a longer quote, but I love it. This is a female who's on the autism spectrum, and this young woman often experiences people who assume that she has little or no empathy, and she herself feels like she has hyper empathy. She can really sense when there's a change of mood or change of emotion. She may not be able to assign a meaning to that, but her knee-jerk reaction is to want to comfort that person and bring them peace. And I love her last sentence. And I can't see it because the block is in front of it of people's faces, but she says she's just as empathetic as Joe Schmo who doesn't have autism. And this coming from a student that I worked with last year. We are people. Treat us thus and we will reciprocate. We have our differences, recognize and embrace them, and we will embrace you. This student graduated from the University of Illinois with his MBA. He was an undergrad in aeronautical engineering, and he's now a contract employee for NASA. So we're very proud of him. I thought I'd address some of your questions about university students. I put them up on the screen just so you can take a look at them. But let me find my notes on that. You asked what the biggest barriers were for students, university students with autism. And I think that what we're finding as we work with university students is that when they get to college, they no longer want to have autism. And that is a big barrier. The amount of students who enroll in support services for their disability is very disproportionate with the prevalence of autism at our university. So we oftentimes are asking ourselves, well, where are these students? We're hoping that as we raise awareness and decrease the stigmatization of autism, that more students will feel like they can seek the support that they need and disclose the support that they need. Another barrier is a lot of these students in this cohort have not been diagnosed. So we know that there are several students at the university who are walking around experiencing the difficulties of someone on the spectrum, but they don't have a diagnosis. Another thing that we're noticing, a question was asked about development that we're seeing through college-age students. We're seeing a lot of students who in their undergraduate years don't identify with their diagnosis. They graduate and either fail at obtaining a job or sustaining a job and end up back with us for a master's degree. And it's really at that time that they're accepting their diagnosis and accepting the fact that they will need support in order to be successful. So really seeing a big difference between our freshmen, sophomores, juniors and seniors being more aware and willing to disclose and reach out for services, but then those 24, 25, 26-year-olds really knowing that without the support that comes with their diagnosis, their chance at being successful in gaining employment is limited. At this point, I just really quickly wanted to go over some of the myths that we want to dispel about autism. I hope that this is the crux of what you've gained from what I've told you. People may think that people with autism aren't interested, they lack empathy, that they have an intellectual disability, prefer to be alone, are disrespectful or rude, or have no sense of humor, when the truth is that they can care deeply about others, can sense subtle changes in the emotional state. They get lonely and desire friendships. They may have low self-esteem or be self-deprecating. They can be very, very funny and are super accepting of others' differences. Another couple of myths are that people can control their autism, that they'll do better if they try harder, and that they just need a lot of advice on how to think and feel. This was something that Barbara Doyle shared. People with autism don't need advice on how to think and feel, but they benefit from learning how to respond in certain situations. They're able to learn strategies to compensate for their difficulties, but it never is natural for them to pick up on social cues or to think flexibly, which means that they're trying much harder in every circumstance than their same-aged peers. I have some references listed if you would like to look at those. And I am going to hand the presentation over to Hena Thakur, who will be talking about females who are on the autism spectrum.
Okay, thank you, Jeannie. I'm going to introduce myself. I am Hena Thakur. I am currently a third-year graduate student in the Clinical Community Psychology PhD program at the University of Illinois. And I've had the opportunity to work with individuals on the autism spectrum through various support groups that we've done through the autism program, as well as the Lighthouse Initiative, and through the University of Illinois Autism Clinic, where we've done various diagnostic assessments. So what I'll be presenting on today are myths and facts about women who are on the autism spectrum. So to start off with, I wanted to provide some statistics, one of which is outdated, as Jeannie mentioned earlier. But in 2014, 1 in 59 children within the United States were diagnosed with autism. And among those diagnosed with autism, we saw that more males than females had been diagnosed. And so collectively, what these numbers suggested was that autism was predominantly a male condition. And we see this message propagated through various media outlets like television shows and movies. And so I have a few examples here. Abed from the television show Community, Sheldon Cooper from the show The Big Bang Theory, which I'm sure many people are familiar with. The main character, whoa, this is going way faster than I would like. I don't have a timer on this, so that's a little weird. Let's try this again. The main character from The Good Doctor, Dustin Hoffman's character from Rain Man. And I wanted to present these because it really highlights the sheer number of male portrayals that we see of autism within the broader community. And that's in stark contrast to the number of female portrayals we see. And so when I was trying to think of female portrayals that most people would know, these two people came to mind, Temple Grandin and Greta Thunberg. And so I think as women on the spectrum become more prominent and become more vocal about their diagnoses, we might start to see an uptake in the number of female portrayals across the broader media and societal world. But as of right now, we do still see that higher portrayal of males. And so what does this mean? Does it mean that males do tend to have autism more frequently than females, or might there be an alternative explanation? And what I'm going to present on today is that alternative explanation, because I think it helps to dispel potential myths about females on the spectrum. So what I want to highlight as an alternative explanation for why we might be seeing more males diagnosed than females is our current diagnostic system. Our current diagnostic system was developed and validated within a male-only sample. And that means that there's a large possibility that we're not adequately capturing characteristics of autism that are found among females. Some of those characteristics that we may see among females include higher social motivation. So what this means is that females are more likely to initiate friendships than are males on the spectrum. And if we think back to what Jeannie presented on, one of the criteria that A criteria of social deficits includes the ability to make friendships. So if females are more likely to initiate friendships, we may miss them on that A criteria and incorrectly misdiagnose them. In addition, among females with autism, we see that they have better ability at integrating verbal and nonverbal forms of communication. And so what this means is, Jeannie also mentioned this, but verbal communication is me talking to you right now. Nonverbal communication would include things like eye contact, gestures, and usually when we're talking, we kind of integrate. We use both of them at the same time to convey our message. And we see that females on the spectrum are more likely to be able to do that than our males. And again, if we think back to that criteria for autism, one of those criteria that you need to meet in order to be diagnosed is this deficit in being able to integrate these two forms of communication. And then a third way in which we may be missing females on the spectrum is that repetitive behavior domain that Jeanne talked about. So females on the spectrum are less likely to demonstrate externalizing behaviors. And externalizing behaviors are behaviors that are aggressive or that involve breaking rules. And females overall are less likely to engage in that type of behavior. But that also means that we're less likely to see some of those repetitive behaviors, because that's usually the context in which they happen. So as an example, if we think of a kid in a classroom setting who does not like transitioning between different classes during the day, he may respond by engaging in tantrum behavior. So screaming, kicking, yelling, and that might be a scenario in which the teacher will more likely say, there's something going on here. We have to figure out why Billy is having trouble transitioning from one classroom to the next. And so in that sense, Billy is then put into the pipeline for being assessed and is more likely to reach a point of being evaluated for autism. Females, on the other hand, are less likely to engage in that type of behavior, even though they still may be engaging in other repetitive behaviors. So another way in which we might be missing females who could be diagnosed with autism. So based on all the characteristics that I just shared of females who are on the spectrum, recent studies found that because of these differences, females have to demonstrate more impairing symptoms, as well as a higher severity of behavioral and emotional concerns to meet criteria for autism. So this creates an unusual divide in who might be diagnosed among females. We might just be capturing females who are demonstrating more difficulties within the classroom, who are demonstrating more difficulties within the workplace, but they have to reach that higher threshold than do males. And then another interesting thing that may be explaining the reason why we see more males diagnosed with autism is this idea of camouflaging. So this is a more recent term that's being used within studies, and is one that's been highly endorsed by females on the spectrum that I've worked with. So I wanted to talk a little bit about it. Camouflaging encompasses two types of actions. The first is hiding behavior that may be viewed as socially unacceptable. How this has been described to me is that females are more likely to notice what the types of things that their peers or friends might be doing to fit in to larger social groups. So they will then try to mimic, wait, let me back up. They will then try to mimic those behaviors in order to more easily fit in. And a popular example is having a hair tie around your wrist and being able to pull on that hair tie and release it as a form of receiving some of that motor stimulation that you might receive in other ways, either through rocking or through spinning, that females just naturally might pick up on as a way to still engage in some of those movements. The second part of camouflaging, the second type of action, involves artificially performing social behavior that's deemed to be more neurotypical. So going back to this idea that females are more easily able to pick up on tactics or ways of interacting that their peers are doing in order to fit in, even though it's less natural for females to engage in some of those behaviors, because they see their peers doing it, they will also start to do those things. And so this is the big question of this presentation, is what does autism look like in females? And some of the ways in which we might begin to characterize autism among females are through higher social motivation, are through less externalizing behaviors, are through better integration of verbal and nonverbal communication. But this is a growing body of research. All the sources, all the references that I used for this presentation were articles and studies that have been done within the past 10 years. And so I think that showcases just how far we have yet to go in terms of developing a definitive understanding of what this looks like. That being said, it also means that our current diagnostic system probably doesn't capture the full spectrum of autism among females. And so in thinking about what this means, I think for me, one of the things that I wanted to highlight were the consequences that come from potentially not being able to correctly identify and diagnose females on the spectrum. And these are three things that I've talked about with females on the spectrum and are things that are very important to them. The first is later access to services. So this comes from the fact that if we are not recognizing autism in females until it is very impairing, until it is of great concern to them, that is more likely happening later in their life course or in their lifespan when they're older than earlier. And so that means later access to services within educational and workplace settings. And these are services that could help them succeed. I've also been told that there's exhaustion and confusion regarding identity. So this directly relates to camouflaging. It takes a lot of mental energy to be able to engage in those camouflaging actions of trying to appear more neurotypical and trying to figure out what might be more socially acceptable. And it's just not a natural way for individuals on the spectrum to interact with others. So it contributes to confusion regarding, is this behavior truly me? Is it something that I'm just mimicking to fit in? And then the last consequence that I wanted to highlight was the loss of vital education. And the most salient example for me is the loss of sex education. There is a myth that females on the spectrum are not interested in intimate relationships. And what that ends up doing is lessening the likelihood that they'll get the sex education that they need. Another part of this is that because a lot of our sex education focuses on the mechanics of intimate relationships and less so on the social aspects, we miss out on the opportunity of providing females on the spectrum and even more broadly individuals on the spectrum the opportunity to understand what is involved socially within those relationships. So it could help them answer questions like, how can I communicate to my partner that I don't feel safe within this relationship? Or how can I communicate that I'm not comfortable with what we're doing? And so this is important because we've seen high rates of sexual assault and abuse among individuals who don't have access to this education. So I've reached the end of my presentation. I hope it was helpful in helping understand some of the myths and facts around females on the spectrum, and I look forward to answering questions later on.
Thank you, Hena, so much for that wonderful presentation. I think that that is a vastly misunderstood area of the topic, and that information was super helpful and interesting. So thank you so much. Aptly describe their expertise in the area. I'd like to start with Dr. Noah Hena. She is a professor in the Department of Speech and Hearing Science at the University of Illinois.
Hi, my name is Noah Hena, and I am a clinical assistant professor in speech and hearing sciences at the University of Illinois, so I'll just reiterate that. My areas of interest really are around where disruptive behaviors and early communication coincide. So my research and my practice really focuses on young children as well as older children who are requiring AAC, alternative and augmentative communication systems, in order to help them learn to communicate. So I love working with parents, and I really enjoy finding functional and appropriate communication systems.
Thank you, Noah.
Mhm.
Our next panelist is Linda Tortorelli. She is the director of the Autism program at the University of Illinois.
Hi, thank you for that introduction. I've been the director here at the university for 15 years. I too have a son that is on the spectrum. He also has a rare genetic disorder. So I come to this career actually through my son. My passion lies in helping families with advocacy and education. I also really am passionate about helping build capacity and working on system enhancement. So really at a lot of different levels, but helping families and individuals and professionals that work with individuals on the spectrum to really be able to navigate the system and have the education available to them that they desire around autism.
Thank you, Linda. We're happy that you're here. Is Amy Cohen on the call yet? It's a little early. We will be hearing from Dr. Amy Cohen. She is at home with young children and has a bedtime, so everyone be thinking about her and sending sleepy thoughts to her house, and she'll be on with us shortly. Noah, I'm going to start with some questions for you. We received your questions when you registered, and this is the time when we're going to get some of those answered. Could you talk a little bit about your area of expertise in AAC as it pertains to how a parent of a nonverbal 3-year-old could be assisted? And perhaps at this time you could discuss when it's advisable to augment communication.
Yeah, that's a great question. So I think one of the biggest things that I think about when I'm looking at an alternative and augmentative communication evaluation, I'm looking to see, first of all, how socially motivated the child is to communicate. And so there's a lot of discussion in the literature and thinking about different children with different disabilities around the use of core words versus fringe words. So I think we want to think about how socially motivated is your child to communicate. And then if they're not as socially motivated, how can we identify items that they would be motivated for? So in my practice, a lot of times children might have preferences, but they view communication as too difficult in order to request the things that they want. So we'll do a full reinforcer assessment to try and look at what it is that's highly motivating for them to want to talk about. There are no prerequisites for alternative and augmentative communication, so the earlier the intervention, the better. There's literature that supports as soon as there's even a suspicion of an autism diagnosis, and certainly if your child is not having their first words in that 12 to 14 months, you definitely want to get an eval and start looking into services, and those could be speech and language services as well as OT and social services.
Thank you. Linda,
Yes.
what have you learned about family interaction patterns when autism is a factor? And how do these families go about telling others around them about their child's diagnosis?
Again, like most families, there's a variety of ways I've experienced responses within the family unit. Often it's the primary caregiver, that's usually the mother, that has suspected for a while that things might have been off with their child. And by the time they're coming to me, they generally have received the diagnosis and have been referred to me for a new diagnosis assessment. It's not uncommon for the generally the spouse or partner that hasn't been the primary caregiver, the husband, to maybe not be at the same point that the mother primary caregiver has been in seeking that diagnosis. And so that's probably the most common that I've seen where, the husband, the father has been lagging behind in accepting the diagnosis. I'm always thrilled when, if there are two parents in a home, that they both come together. And the best is when they bring the grandmother with them as well. Those situations really are exciting for me because the whole supportive unit is there and ready to get going on this diagnosis and accept it. But that doesn't happen always. It might just be the mother that's coming and really seeking that information. So it really can vary. It can vary culturally as well. We have a very diverse community here being housed at the university. So I can see this level of acceptance within family units varying somewhat by the cultural acceptance as well as autism. And the concern that parents sometimes bring to me that they're here for a short while, but going back to their home country, how would they explain this diagnosis to the grandparents or the extended family, and having great concerns about carrying that with them back to their home country. So I don't know if I fully answered both those questions, but.
Thank you. I think that hits on a lot of really poignant points. I see that Amy is on the call now. Dr. Amy Cohen, the director of the Autism Clinic at the university. Are you available, Amy, to give an introduction?
Hi, Jeannie. I am here. I am trying to figure out why my video will not show up. So if I'm the last person that needs to give an introduction, I'm happy to do so. Otherwise, I'll continue to try to figure this out.
Go ahead. Well, probably figuring out and introducing is tricky. I'll field another question back to Noah, and let us know when your video pops up, because I think we'd love to see your face.
Okay, will do. Thanks.
Okay, Dr. Hena, there's some questions about best practice for teachers and social workers who work with children on the autism spectrum. What advice would you give these professionals?
I think one of the most important things for our students is to establish early routines and be able to use your visual supports to help children navigate new classroom settings, new changes in their routines, new experiences, so that they're able to fully participate. I think that working together as a team can often be difficult, but I can only encourage you to make that the highest priority, because the child's best interests are really what's the most important thing.
Wonderful. Thank you so much. Amy, are you with us yet?
I am here, yes.
Oh, there she is. Wonderful. Please introduce yourself. We're happy you're here.
Sure. So my name is Dr. Amy Cohen. I am the director of the University of Illinois Autism Clinic and the Psychological Services Center at the University of Illinois in Urbana-Champaign. I am also a clinical assistant professor in the Department of Clinical and Community Psychology. So a brief summary of what we do. I'm a licensed clinical psychologist. I specialize in working with children and adolescents, and in particular, people on the autism spectrum. So that's a very brief overview about myself in the clinic.
Thank you for that. I'm going to hit you right away with a question.
All right.
We got a new question here in the last 24 hours that maybe you might not be as familiar with, but I think it's
good. I'm glad you're starting with one I'm not familiar with, Jeannie. Thanks.
You're welcome. So this member of the group asked if what's being done about the disparities in resources among African Americans with autism. Do you have any information about that? And if there's anyone else on the panel that can add to that, I'd appreciate it.
I think the first step, which is one that we've taken and is a good one, is to recognize that that disparity exists, first of all. I think for a long time we conceptualize this as sort of a disorder of white kids, of upper class white kids, And I think now researchers are looking at this critically and saying, like, well, why are we differentially diagnosing children? Where does this disparity come from? And we know that it's coming from access to resources, and that anybody who's gone down the road to get autism diagnosis knows this is a long road and it's a persistent road. Especially if you have a child that isn't a parent, doesn't come with your classic autism signs. So as the parent, really need to advocate for your kids, and inherently that's going to pull for a ton of resources on the parental level too. So I think the first step is awareness, to recognize that there is this disparity and we need to do better, and we're there. We've done that. Oh, there's a problem with my microphone. I'm seeing. Can no one hear me?
We can hear you. You're cutting in and out.
Okay, that's not very helpful, is it? Okay.
Well, I heard most of what you said. Honestly, it was good. It was just a little bit wonky.
Okay. Okay. I think the next piece that we have to do is to try to sort of take our screening and our diagnostics to a more community level, sort of recognizing that pediatricians, teachers, daycare workers are largely our first line of defense. Anytime somebody comes to me as a clinical psychologist, somebody already pointed them in that direction who along the way had an idea of what to look for. So I think broadening our understanding of the diagnosis as a community, doing more parent education is huge in order to support people being aware of the disorder and how to best support these minority kids that also qualify for a diagnosis.
Thank you, Dr. Cohen. Linda, I'm going to come back to you. What's your advice about communicating with school staff that appear to believe that a child's difficulties are due to behavior and parenting style?
Well, first of all, hopefully the teachers that are working with your child are aware of the diagnosis. So making sure that anybody that's interacting with your child at the beginning of the year, that you have disclosed to them. Don't just assume because they have a 504 plan or an IEP that everybody that comes in contact with your child is going to know about their diagnosis and about the supports that they need. So if that's a concern of yours, that your child's going to need a support across their day by all professionals, then I encourage you to find a way to disclose that with your team to those individuals. So if you have people then that are, after you've done that, are still thinking that it's bad parenting and not related to their disability, if they have any behaviors that are interfering with their education or the education of their other students, they should have supports in their IEP process. So they should have a behavior intervention plan if they're having consistent problems with behavior that's interfering with learning. And that behavior plan should be based on a skilled professional that knows how to do a functional behavior assessment. And so the behavior intervention plan is part of the IEP that, again, is driven by a functional behavior assessment that determines really why these behaviors are happening. So it's not okay. And again, sometimes these kids don't even have an IEP or 504. So if they don't have any of that, and you've disclosed the disability and the school says, well, it's not interfering with their learning, they don't need any support, well, this would be a time to point to that support if the school staff is coming back to you and saying, here's these problems. And you would have to request formally to have the team get together, or that there's be some assessments done about the behavior. It's not okay if a teacher is repeatedly coming back to the parent and complaining about behavior and not doing something about that.
Thank you. I think that's a pretty that can happen frequently within the school system. I work with a lot of very well-intentioned teachers and a lot of frustrated parents. And I think you hit on a really important point, that the communication is key in building those relationships while advocating for the rights, because teachers are working hard.
go back to that point about disclosure again. And so for parents, you can't really have it both ways. You can't hide your child's diagnosis and then have an expectation that people are going to treat them fairly. And so, and also hide the diagnosis from the child and think that, you know, everybody should just by osmosis know what's going on. So this is where we really have to have some open lines of communication and, you know, come out about the diagnosis of autism and what the child needs.
Thank you. Wonderful. Noah, I'm going to go back to you. There's a question about ABA, and Noah is a BCBA. So maybe you can describe a little bit about what ABA is. And this question is ABA affected? And if so, how many hours are recommended?
So ABA is the applied behavioral analysis, and it's a set of scientific principles that predict behavior. And so we use ABA all the time in our social interactions. We use them for a variety of disabilities. I want to emphasize that ABA is an umbrella term and that a lot of different strategies fall under that umbrella term. I think that often in my work, when people say applied behavioral analysis, there's this immediate thought of discrete trial training. And so I want to make sure that people understand that there's many different things. A lot of my work in communication in AAC relies on ABA, and it doesn't look anything like discrete trial training. So there's other things to think about there. So in 2001, the Research Council recommends 25 to 30 hours of active engagement. And so for each family, that can look differently. So for some of our children, they receive ABA services and an evaluation is done and recommendations are made, and that's discussed with the family. And I think sometimes that recommendation gets confused with they need 25 to 30 hours of ABA services. It's actually active engagement, and that could be with your family, that could be with your extended family, that could be direct services, that could be speech or OT. And so again, I'm just going to go back to thinking through who's on your team, what goals have we all agreed on, what evaluations have been done, and then the last thing I did want to say, going back to Linda's discussion about a behavioral assessment versus a behavioral analysis. I think we do a lot of behavioral assessments in the schools because that's where it's safe. If you feel that that's not getting to the root of your problem, you could go and to an outside agency and actually do a behavioral analysis where we are trying to elicit the behavior in order to collect data to better understand the function of the behavior. And Amy, anything you want to add to that, you just jump in.
Amy, I am going to ask you I'm going to combine a couple questions here. And so if you want to tag on to Noah's response, that would be fine. So this question is, could you give a brief explanation about the history of the autism diagnosis and the difference between autism, ADHD, and mental illness? And kind of as you're addressing that, I'm wondering if you could tag on a little bit of information about, there's a lot of talk out there about vaccines and causes of autism, and then also probiotics and whether they help people who are on the autism spectrum.
Okay, I will try that as
from A to Z in one response.
There are 4 unrelated topics, but I will do my best to totally tie them together. In terms of the broader history of ASD, I won't spend a ton of time going down that rabbit hole, I will just say that we should know that as a disorder, it is in its relative infancy compared to other disorders. Childhood disorders in general, when we think about autism kind of starting out as a childhood diagnosis, are relatively young compared to any adult diagnosis within the field of psychology. But autism in and itself is particularly young in that way. So it wasn't until the 1940s that Leo Kanner, who was an out of Austria and ended up coming to Johns Hopkins after World War II, started identifying these kids. And at the same time that he was kind of looking around and seeing these kids that sort of share these collections of traits, Hans Asperger was seeing the same thing in Germany. But unfortunately, the times being what they were, World War II isn't exactly the best time to spawn research collaboration. So these men very much did their work in parallel. And it wasn't until after the war, until 1953, that autism actually made its way into the DSM, which is, for anybody who's not speaking psychology on a day in, day out basis, that's sort of our diagnostic tome, our Bible that we go by in terms of where our general spreadsheet of things are. And I want to check in quickly. Can everyone hear me okay? Better. Okay, wonderful. Wonderful. Even at that time, early on, we still thought about autism basically as a form of childhood schizophrenia. That's very much how everybody sort of thought about it, is that these were children who were sort of turned inwards in a way where they were experiencing more psychotic symptoms than they were anything else. The word autism itself actually comes from the Greek word autos, which means self or inward. And it was really meant to talk about these kids who were self-isolating and turned inward, rather than seeking socialization as we neurotypically think of it from the outside world. So we have that sort of shift, and then in the early 50s, 60s, we get this terrible label about refrigerator mothers. For any parent and for any mother in particular who has a child that is struggling in any way, we tend to blame ourselves just by virtue of being a mom, especially when you have an entire medical field telling you that you've caused this is your problem. So the refrigerator mother idea was this idea that mothers were so cold and unfeeling that they caused this autism within their child, which we know is patently untrue, but we've seen that sort of kind of haunt the field of autism, and there still are vestiges of that today, this idea that there's a maternal impact. From there, we moved to the next version of the DSM, which basically conceptualized ASD among a score of developmental disorders. So there was 5 within that autism spectrum, and those included Asperger's, which everybody is probably familiar with, classic autism, Rett's disorder, which we see primarily in girls and is marked by motor impairment, childhood disintegrative disorder, which we see marked by rapid loss of regression in skills in kids under the age of 5, and pervasive developmental disorder not otherwise specified, or PDD-NOS. So those kind of carried us through the 2000s, late 90s, until 2013, when we decided that looking at the data and looking at the consistency of diagnoses, that it didn't make sense to sort of subdivide developmental disorders, pervasive developmental disorders in this way, that it made more sense to house everything under the idea of autism, and then to think about within that, how are people on the spectrum functioning? I will take a moment here to say I hate the labels of high and low functioning. I hate everything that they connote, everything that they carry with them, but that is how they meant to sort of differentiate amongst people, to give these sort of ratings amongst people on the spectrum as a way of saying how people are rating on their skills, where they're at. So that is a long-winded answer to one part of your 4-part question. The next part, I think you were asking about how you differentiate autism from ADHD. And I think another important thing to say here, and Jeanne, you might have said this in the beginning when you were running down diagnosis in the first part of this talk, but that it's really important to recognize, especially if you are a parent who's on this call and wondering if this diagnosis fits your child, that any of these things that Jeanne talked about in isolation are totally typical. And they're typical up until a point, right? So if you have a child that's especially into trains, but you're not seeing any other symptoms, you might just have a kid that likes trains. Same thing if you have a child that can't make eye contact or is very shy, you might just have a kid that's anxious. So for anybody that's on the call and hearing these lists of symptoms and thinking, oh my goodness, that's my child, I just want to emphasize that all of these things are typical up until a point. Where we start differentiating is when these symptoms start hanging together and when we see these sort of broad swaths of impairment in social communication as well as in restricted repetitive behaviors. So there are pieces of autism that can look like any other disorder. You know, it can mimic anxiety. A lot of times children will come to us with a misdiagnosis of OCD, obsessive compulsive disorder, because somebody will hear about kids doing things in a rote, repetitive way and assume that that's ASD. A lot of times we also have an ADHD diagnosis come our way, because with extreme ADHD can come extreme social impairment. Obviously, if you're a child that is especially hyperactive or that is really having trouble focusing, that's going to cause impairment in other aspects of your life. But it's really when we see these constellation of these things hanging together that we see the social difficulties combined with some of the B criteria that Jeanne talked through, these restricted and repetitive interests that leads us down a path of autism. Also, as a diagnostician, we really take into account developmental history. So when did these things occur? What was the time course, the onset of symptoms? The DSM tells us that it has to be early childhood. So we know that you can't, you know, at 18 all of a sudden have an onset of autism, but that would rule this out. Okay, again, a long-winded answer to that question. Probiotics, I think, was next. Okay, wonderful. So there's a whole other part of the field called complementary and alternative medicine, or CAM. This is something I like to talk a lot about, that I'm really passionate about, because I understand as a parent the tendency and the motivation to look for anything that you can to help your child. I also understand the tendency in people who are on the spectrum and who are struggling with these things to want to help themselves. I think it's really hard to sort of slow down when you are panicked and when you are thinking, what can I do or what am I not doing to help my child? To look at what sort of the data and the science is behind evidence-based treatments for people on the spectrum. One thing we know about probiotics is that there has sort of been a school of thought about this leaky gut theory, or you've probably read a lot about the gut microbiome in autism. It is no surprise, and we know we've got the data to support it, that there are GI difficulties within autism spectrum disorders. More often than not, we hear a lot about children who have impacted bowels, who are taking Miralax, who really struggle with GI distress. You know, obviously something physical like that isn't going to make its way into our symptom criteria, but it's one of those sort of secondary symptoms that we often see hanging around this disorder. So because of that, people have sort of gone down, understandably so, this idea of let's address the gut microbiome, try to rebalance it, try to take out some of the bad bacteria, replace it with good bacteria. There's currently RCTs going on out of McLean that are trying to look at this and address this more scientifically. But what the microbiologist at McLean would tell you is that there's no proven effect for probiotics at this point. That when you see the sort of anecdotal evidence that pops up about, oh, my child started this probiotic and then they started speaking, or other really miraculous claims, I always sort of look at those with a skeptical eye, because it's not going to be one magic pill across the board that's going to make any child sort of suddenly verbal. So what their line of recommendation is from the folks who are studying this is, if you want to try out a probiotic, to start with something like a probiotic yogurt. And those are really clearly labeled. You can find them at the supermarket. And just sort of look and see if there is an impact of that probiotic on your child. The thought being, what you would look for is the alleviation of those secondary symptoms. Do their stomachs seem more comfortable? Are their bowels moving more easily? So looking sort of for those, but not expecting to start a probiotic yogurt and to see a difference. The other caution I would put forth, as it's not an evidence-based treatment behind it now, is that probiotics, because they are marketed as supplements, are not regulated by the FDA. And because of this, you'll see sort of a proliferation of people out there who are sort of selling things across the board marketed as a probiotic, and not all probiotics are created equally in that regard. So that's just another thing that I would put out there to say as a note of caution. The last cautionary note that the microbiologist would share is that there's this idea that we could develop a resistance similar to what happened when penicillin was first invented, where there was this sort of overuse of penicillin, and then we developed sort of resistance to that as a result. There's some sort of note of caution coming out of that community that we just have to be careful with how readily we rely on probiotics for the same sort of reasons. Okay, that was question 3. I blanked on question 4.
Vaccines.
Oh, okay, right. Another small topic. Vaccines. I like that you're hitting me with all the contentious ones. So I will just say this, and to share what the data says. Obviously, this is a topic that people are heavily invested in on either side. It is a lightning rod topic, which is why I'm so glad you've tossed it to me. People can direct hate emails my way. But there really is no scientific evidence to this point saying that there's a connection between vaccinations and children developing autism. You know, the one study that everybody points to is the Lancet study that was done years ago, where everybody was, you know, there was allegedly an RCT that followed these kids and how they progressed after vaccinations. That study was discredited for a lot of reasons, but I think the imprint that it has had within the societal understanding of vaccinations has left an unfortunate lasting impact. There is a lot of misinformation out there, and certainly it doesn't take much to drive by a billboard of a child who is injured and to see something written about vaccinations and to think, my God, I'm going to think twice before I bring my child to the pediatrician to get a vaccination. But there really is no evidence-based connection between a diagnosis of autism spectrum disorder and a vaccine.
Thank you. I think you deserve a deep breath and a glass of water after that. Thank you so much. All of you are such impressive experts in this area. I think it's time to open up to the chat for some questions. While the chat is populating, I'll read the first question. What should we do as educators when a child clearly needs more help, but the parents are reluctant to advocate? I feel as if parents don't advocate. If the parents don't advocate, they just get lost in the shuffle. And I'll direct that to you, Linda.
I think you're right. There's always so many resources. You define resources any way you want: money, time, energy, attention, to go around. And it is the greasy wheel that gets squeaked. That's the way it's always been. It's the way it's always going to be. As an educator with a disengaged parent, I think every building I've discovered has its own culture within the culture of an entire school district. So I think as an educator in your building, in your grade, I know you have your own hierarchy of how you bring concerns up the ladder. And so following your chain of command for bringing those concerns, you know, either to your weekly team meetings within the building, to your vice principal that I know in our local district might be head of the special ed department. And I would continue to do that. If the parents really have been unreceptive to your reaching out, then do your very best to advocate for that child within the structure of what you can do within your building. That's about all you really can do.
And I find it very encouraging that there are educators on this call. There's another question that I think I would like to, while we're waiting for the chat to populate, I'd like to toss it out to everyone, and I'd like to maybe give you a second to formulate one sentence. I think sometimes formulating one sentence is a lot harder than formulating 5 sentences about something. But, and Hena, I'd like you to join into this too. A question was, could you give a brief statement on how you feel educators can help break the stigma autism carries? And I'll go ahead and start while you are formulating your thoughts on that. I think that, again, not shying away from the word autism is important, and creating a classroom where differences are embraced and supported in a transparent way is the best way to break the stigma of really any disability, especially those non-visible disabilities. Who'd like to go next?
I'll take a moment. I don't know if I could do it in a sentence, but to break the stigma, I think education is always the key, in educating children around those words we hear as labels, and treating them all equally. ADHD, what does ADHD mean? Does anybody know what that means? What does autism mean? And what is OCD? You know, some of these labels, when I'm doing peer education, I always start with the ADHD, and oh my goodness, all the kids light up like, I have that, you know, and just even destigmatizing that is a really great start. So using April for autism, bringing that into your classroom in so many ways. I have been in some schools, particularly some of our rural communities do an amazing job of bringing neurodiversity and other diversity into their schools and really embracing it, and aren't afraid of it as much sometimes as I see some of the bigger schools. So yeah, I would do as much as you can about destigmatizing all labels whenever you have the opportunity to do that in your learning.
Anyone else want to take a stab at that one?
I'll take it. I would just expand on this idea of creating a culture of understanding and empathy in your classroom to the extent that you're able to. One thing that we're not talking about within the context of this talk is the idea of the neurodiversity movement and the idea of accepting people kind of where they are, and the different strengths that people bring to the table and the different difficulties that people present with. And I think now more than ever, our adolescents and our kids face really unique stressors that none of us understand. These kids are in a unique pressure cooker at all times because of social media, because of the fact that the judgment is so outrageous. And at the same time, at the other end of that, I think we are seeing generations of kids who are much more open and are much more understanding that people can present in the way that's true to them, and to sort of fostering this culture of openness and understanding as much as you're able to view every child's strengths as their strengths, and their weaknesses as their weaknesses, and to move away from the idea of labels and the idea that this is who this person is and we accept them for what they bring to the table.
Thank you. Unless someone has something really heated that they'd like to say on the panel, I think I'm going to go to the chat since we do have some questions there. The first one, in informal education, we must accept and reach all youth, but often we are not told about a child's needs, nor do we have the support that a child or that the child may have in the regular classroom. How do we meet that child's needs as well as all of the other youth? Do we push or allow them to find their own way? Any thoughts on that?
I'm happy to take it again, and then anybody jump in at any point. Yeah, I resonate with that question. I understand it completely. My mom was a first grade teacher, and it was always interesting for me to have conversations with her about what I was doing on my end as a clinician, and then the reality of actually implementing those things in a school district. Obviously, we know school districts are strapped. Most teachers are strapped. And a lot of the times, our frontline recommendations that we think are best practice are met with resistance because of manpower, because of money, because of whatever it may be. I think one of the really important things there is an open and honest line of communication with parents as much as you can foster that. That is going to be your number one ally in this with the child's learning. And I always recommend that regardless of the age of the child or adolescent, that there's a notebook that goes home between the parents and the school just to have communication about what's happening at the very least. I know a lot of parents text back and forth with teachers these days. But that is a struggle that I completely empathize with. How are you supposed to dedicate all this personalized attention to this one child who absolutely needs it, and at the same time you've got potentially 30 other children in your room that you need to educate and keep up to speed as well? And I would just be as open and honest as you can with the parent about the struggle and what you're trying to do, and then keep trying to advocate within your district. I mean, it's true for parents and it's true for teachers that the squeaky wheel does end up getting the grease in these situations. So there's not an easy, straightforward answer other than to say that I feel that struggle, I feel that as a challenge, and use a parent as your ally to the best of your ability.
Thank you. I'm just a little tag to that. Whether you are a Taekwondo teacher, a music teacher, a youth pastor, meeting the needs of all the children is difficult, but I think what we find is that there are certain strategies that help some of these children with special needs that help every child in your class or in your environment. And finding those key strategies that support the learning of all the students, I think, is really important. Another question here, this is for Noah. Are all nonverbal children considered autistic? My husband didn't fully speak until he was 5, and on my side of the family, I had about 4 cousins who were late talkers as well. They are all grown adults and seem to be doing okay.
Yeah, I saw that question, so I'm glad I can address it. There are many, many reasons that children are nonverbal. Some of them have physical disabilities. Some are kind of what your family seems to be experiencing, maybe late talkers. I would still encourage, if your child is not having their first words in that 12 to 15 months, to still seek out treatment and make sure that they're supported as much as possible. But yes, there are many diagnoses where children are nonverbal or late talkers. So that was a great question.
Thank you. Another question here, and Hena, I'm going to put you on the hot spot because you are the one who's been in this headspace. It says, hi everyone, adult autistic woman here. Could you please talk about the myth that autism affects mainly or only cognitive, emotional, and social differences, and address some truths about the physical and body differences that impact us?
I think I might ask Amy to answer this one. If there's anything that I can add, then I will add, but she's the ultimate expert, so I will
Okay, wonderful.
go to her
Amy,
expertise.
Sorry, I'm going to be totally honest. I was not listening to that question. My child was screaming in the background. So can you?
That's okay. If you need to get going, please let us know.
Dad is on it. We're good.
This is from a woman who is on the autism spectrum. She's asking you to address the myth that autism affects mainly or only cognitive, emotional, and social differences, and address some truths about the physical or embodied differences that impact women.
You know, there's been some interesting, that's a great question, first of all. There's been sort of split data around that. And I think the most interesting data that's come out of it is this idea that women on the spectrum, and there's been some papers published around this, though I would not actually put a lot of stock in them, around there being physical differences with women on the spectrum that they present as more masculine. And that has even looked in these papers as like measuring digit length and ratio. So, you know, people have done that work. I would not say physically looking at someone that you can make a distinction that yes, they have autism or no, they do not. We know there is more gender fluidity in autism generally than there is in the broader population. And some people will sort of tie that back to it being the same sort of argument about these differences. I don't think it is. I think the gender fluidity question is an interesting one and deserves further exploration, but I don't think it's tied to any phenotypic or physical appearances. What was I also just going to add to that? I had somewhere else I wanted to go.
Amy, I think definitely the low muscle tone we see in people on the spectrum, that is sometimes quite noticeable, not just in women, but in males as well.
Yes, and thank you. That just jogged my memory, Linda, of what I was thinking. We do see motoric differences, so differences in how people move their body and how they interact in space. So as part of a really interesting study that looked at just upon greeting, sort of how people on the spectrum, what their motor fluidity was when they went to shake somebody's hand, how fluid that was. And we know that motor movements within ASD are more rote and stereotyped than people who do not have a diagnosis. So it's kind of interesting if you think about it almost mirroring the social emotional piece, is that there's less social emotional fluidity, right? You're more likely to respond in sort of rote practiced ways that you've known because you've learned them. Motor movements tend to mirror that, in that they tend to be more stereotyped. So people on the spectrum can sort of, people will say that they have a spectrumy look about them. And I think that's sort of this discomfort in your own skin, this sort of discomfort with how to position my body, what looks most normal at that point in time, along with the fact that the motor movements can be more rigid. If anybody remembers, this is going to date me, but the child that went viral, I think 10, 15 years ago now, he was a child on the spectrum that played basketball and shot 3-pointers and set records at his school because he was able to shoot these 3-pointers with startling accuracy every single time. And if you look at the footage of him shooting, it was just a rote movement, that he knew his spots on the court and he knew if he was there that he could hit that. So yes, motoric movements are different. Like Linda was saying, we can see low motor tone in children on the spectrum as well. But there's not, you can't look at somebody and know definitively, oh, this is an autistic kid. Autism doesn't present with a physical phenotype in that way.
Thank you. I'm going to circle back to some of the questions that were given to us during registration. Linda, do you have any tips on creating an autism-friendly environment? We had one participant who works at a museum. I think that's where I'm drawing this question from.
Okay, and I do see it's 8 o'clock, so I want to be conscious of time and just keep it short. But any environment that's open to the public that has additional information presented in a way that a more a visual way, exhibits that might have additional information, that might have some pictures about, so that not only a person on the spectrum, but maybe a non-English speaker or somebody that's a non-reader could understand what those exhibits might be about, can be really helpful. If you have exhibits that have, sometimes you go to really interactive museums and they have recordings going on that can be really loud and obnoxious, that might not be the most friendly environment to have unexpected noises going on. But really, I think museums are a wonderful area for people on the spectrum to really, because they're very interested in factual information. And so museums are a great place. I know my son, who's 30, loves museums of all kinds and really enjoys them. And I think overall, the modern museums have done such a great job of making exhibits interactive and doing a lot of this supporting what you're looking at in multi modalities, that I really think that museums have come such a long way. And that's why a lot of my son, I know, loves them, and a lot of people on the spectrum already do. So I don't think you have to look far as a museum curator for wonderful examples of how to enhance your museum exhibits just by looking at other museums.
All right. As Linda mentioned, we are approaching the 8 o'clock hour, and I want to thank, first of all, the Autism Program for sponsoring and providing this event. Dr. Aaron Abada, who is behind this, the wizard behind the scenes. He is helping with all the tech and running all the tech. Thank you, Dr. Abada. Thank you, Linda, Dr. Cohen, Dr. Hena, for providing your wealth of expertise and information. Thank you to all of you participants. Your participation shows us that there is a community out there that cares about these individuals, that cares about the advancement of knowledge and advocacy for people who are on the autism spectrum. I see a really bright future for these people. And just as a last note, we will be providing you with resources here within the next day or two. And there will also be a videotaped segment, or this presentation will be provided on video. So if you have someone who didn't get a chance to attend this evening, you can forward it to them, or you can have them contact me for that information. So we'll have written materials and a video for you here shortly.
I do want to mention we have 2 more already scheduled coming up. Next week we'll be with Lisa Crane, a speech pathologist, and she is an expert in picky eating and feeding issues, particularly with people on the spectrum. So I hope you'll join us next week at the same time. And the following week is one of Dr. Cohen's, another student of hers, Dustin Harden, who's going to be speaking about sleep issues in autism. So I hope you can join us for that. Dr. Cohen and I have some other ideas that we're cooking up. I don't know if you want to give a preview, Amy, or if we should save that.
I will preview it because I'm excited about it. And I'm twisting Linda's arm to do this, so I appreciate it. But we are just recognizing that this is really just a trying and stressful time for everybody. Certainly if you are a person on the spectrum or if you are a caregiver of someone on the spectrum, this is just appended everyone's lives. And so recognizing that it takes a community and a village to raise a child, and your village has probably largely gone quiet or virtual during this time. Now, Linda and I were hoping to step in and offer just like an hourly support group. It'll be later, probably 8 to 9, targeting the first one at parents and caregivers. And this would be a low-key, relaxed event. We're picturing it more intimate and really just built around offering support and encouragement to people at this time. So bringing whatever's relevant in your life to the table. I'm calling it the wine down, the implication meaning that I will probably be having a glass of wine during that. I would encourage you to do the same if you are so inclined. But keep an eye out for that. We're hoping to offer that soon.
Great. Thank you, everybody. Our final goodbye again. Thank you so much. We hope to see you all in the near future. Stay well. Good night.
Bye-bye.